Hi, my name is Maria Elisa Mejia and my co-authors are listed here. I will present optical coherence tomography and angiography features as predictors of visual outcomes in eyes with retinal vein occlusion treated with intravitreal anti-angiogenic therapy. These are the financial disclosures. Retinal vein occlusions are the second cause of retinal vascular disease. In most cases, vision loss is caused by macular edema. It is estimated to affect 14 to 19 million of persons of worldwide population. The annual global prevalence for both branch retinal vein occlusion and central retinal vein occlusion are shown here. All types of retinal vein occlusion are associated with atherosclerosis risk factors. The major risk factor is having retinal vein occlusion in contralateral eye. Intravitreal anti-angiogenic therapy and steroids have shown to reduce macular edema and improve vision in patients with retinal vein occlusion. However, some patients only have partial visual improvement despite complete resolution of macular edema after anti-angiogenic therapy. In such cases, there are possible causes for residual visual impairment, such as potential abnormalities in macular microvasculature. These abnormalities are not identified with conventional fluorescein angiography or spectral domain OCT because of their limitations. Several studies with OCTA have been performed in eyes with retinal vein occlusion. They report abnormalities in vascular plexus of the retina, with a greater involvement of the deep vascular plexus, increase in foveal avascular zone, changes in perifoveal microcirculation, and presence of microaneurysms, collaterals, telangiectasias, and non-perfusion areas. Nevertheless, few studies report the association of these findings with visual acuity and after treatment with anti-VEGF therapy. The purpose of this study is to describe clinical and morphological findings on OCTA in patients with retinal vein occlusion and associate OCTA features with visual outcome after anti-VEGF therapy. An analytical observational study was performed in eyes with retinal vein occlusion treated with anti-VEGF between January 2018 and December 2019 at Fundanal. This study was approved by local ethics committee. We used OptiView OCTA system. Measures were analyzed including superficial capillary plexus, deep capillary plexus, foveal vascular zone, and macular ischemia. We consider manual segmentation was safer and more reliable since macular edema may have altered the anatomy. Statistically, analysis included OCTA measurements before anti-VEGF treatment, analyzed with final visual acuity to determine their association as predictive factors for visual outcomes. Logistic regression analysis was done. We extrapolated Bradley classification of diabetic macular ischemia to evaluate the stages of macular ischemia in our retinal vein occlusion patients. These grades are based on parafoveal area and foveal vascular zone. Grade 1 is normal without disruption of foveal vascular zone. Grade 2 is where the outline of the foveal vascular zone is not clearly smooth or oval but not clearly pathologic. Grade 3 representing a mild macular ischemia where the outline of the foveal vascular zone is destroyed for less than half of the circumference. And grade 4 involving severe cases of macular ischemia where the outline of foveal vascular zone is completely destroyed. 62 eyes of 62 subjects were included in this study. 56% were females with a mean age of 70 years. The median follow-up time was 21 months between the first OCTA at baseline and the last injection. 46% had central retinal vein occlusion, 46% had branch retinal vein occlusion, and 6.5% had hemicentral retinal vein occlusion. The most frequent personal history was hypertension with 38%. Subjects received an average of 4 anti-VEGF injections, including ranibizumab in 35%, aflibercept in 35%, bevacizumab in 20%, and combined anti-VEGF therapy in 8%. Median best-corrected visual acuity change from pre-treatment to post-treatment for each type of occlusions are listed here. These differences indicate a statistically significant improvement in eyes with central, branch, and central retinal vein occlusions. Patients with branch retinal vein occlusion had better final best-corrected visual acuity, but this visual result did not show any statistical association according to the type of occlusion. Worse vision at baseline was associated to poor final best-corrected visual acuity. Here we can see OCTA findings before and after anti-VEGF therapy. There was a statistically significant change between central retinal thickness capillary densities in both plexus and foveal avascular zone before and after treatment with anti-VEGF. Preservation of the external limiting membrane and ellipsoid line was present in the majority of eyes. Microaneurysms and telangiectasias were more commonly found in the plexus. Non-perfusion areas as well as collaterals were found equally in both plexus. We used macular ischemia grades based on parafoveal area and foveal avascular zone. We divided according to superficial capillary plexus and deep capillary plexus. For both plexus, there was a higher number for grade 3, followed by grade 4, with less number for grade 2, and finally without any eye in grade 1. Associations between OCTA findings and final visual acuity show central retinal thickness and both capillarity densities had a statistically significant association with final vision. Capillarity densities show negative correlation values, meaning that the lower the capillarity density, the value of best-corrected visual acuity in logMAR is greater, representing worse visual outcome. Those who presented grade 4 macular ischemia had poor best-corrected visual outcome. This association was statistically significant. No other associations were found, neither for final vision or dividing results by type of occlusion. The logistic regression analysis shows that the variables that best explain the visual result in this study were baseline visual acuity, central retinal thickness, and foveal superficial capillary density were statistically significant. No other variable was significant in the regression analysis. The limitation of this study included its retrospective design. Relatively few subjects did not allow an adequate analysis of association by groups. A varying number of anti-VEGF injection comparing different types of anti-angiogenic treatments. We included patients not naive to anti-VEGF therapy. Macular edema have altered manual segmentation and differentiation of plexus and therefore the measurement of capillarity densities by plexus. Our OCTA version does not allow the differentiation of the foveal avascular zone between the deep and superficial plexus. It takes it as an absolute value for the full retina. The conclusions of this study are retinal vein occlusions have decreased overall vascular densities in both plexus associated with worse vision acuity. Grade 4 macular ischemia is more common in both plexus associated with worse visual acuity. Baseline visual acuity, central retinal thickness, and foveal superficial capillarity densities were the variables that explain final visual results by 40%. Thank you for your attention.